Hello, I'm Manoj Karmakar. In this next video, Dr. Justin Ko from the Sungkyun Kwan University School of Medicine in Seoul, South Korea, is going to be discussing with us ultrasound assessment of the hemidiaphragmatic function and phrenic nerve sparing blocks for the upper extremity. If you're enjoying our videos, do remember to like and share these videos. If you still haven't subscribed, do remember to subscribe so that you can get regular notifications of any future uploads. Now enjoy the upcoming video.
Hello, I'm Justin Ko from Samsung Medical Center in Seoul, Korea. It is my great honor to participate in this very special meeting. Today, I will be speaking about the ultrasound assessment of hemidiaphragmatic function and phrenic nerve sparing blocks for upper extremity surgery. I have nothing to disclose. This is Samsung Medical Center located in Gangnam, Seoul, Korea. It is a 2,000-bed hospital with 56 operating theaters, and we perform around 200 surgeries every day. And I work here as a liver transplant anesthesiologist, also the regional anesthesiologist. The interscaling block is a valuable analgesic option in shoulder surgery. However, phrenic nerve palsy and hemidiaphragmatic paralysis are very common after interscaling block. This has significant clinical implication in patients at high risk of respiratory complications. As you know, the innervations of the human shoulder joint are provided by suprascapular nerve and axillary nerve. Both are the branches of the C5 and C6. Therefore, interscaling block, which target the C5 and C6 roots, are most commonly used to provide analgesia after shoulder surgery. However, conventional ultrasound-guided interscaling block is associated with high risk of phrenic nerve palsy. This particular study showed 100% incidence of hemidiaphragmatic paralysis associated with interscaling brachial plexus anesthesia. The large volumes of local anesthetics ranging from 34 to 52 milliliters of 1.5% mepivacaine was injected, and all the patients had hemidiaphragmatic paralysis and showed a paradoxical upward movement of the ipsilateral diaphragm during inspiration. In the chest X-ray, you can clearly see the elevated diaphragm on the affected side. The anatomy of the phrenic nerve is key to understanding the basis for the strategies to reduce the risk of phrenic nerve palsy. The phrenic nerve originates primarily from the fourth cervical ventral ramus, but also receives contributions from both third and fifth ventral rami. The phrenic nerve descends from the root of the neck through the thorax and terminates at the ipsilateral diaphragm. This is an ultrasound study of the phrenic nerve in the posterior cervical triangle and discuss the implications for the interscaling brachial plexus block. In Figure 1, at the cricoid cartilage level, the phrenic nerve is adjacent to the brachial plexus, and in Figure 2, at 1 centimeter caudal to the cricoid cartilage, the phrenic nerve is identified medial to the brachial plexus, superficial to the anterior scalene muscle. This study illustrated that the phrenic nerve lies within 2 millimeters of the brachial plexus at the level of cricoid cartilage, but it moves away from the brachial plexus by an additional 3 millimeters for every 1 centimeter that it descends into the root of the neck. This excellent review article focuses on the phrenic nerve palsy and regional anesthesia for shoulder surgery. And this picture illustrates the course of the phrenic nerve in the neck. As indicated, it lies within 2 mm to the C5 root at the cricoid cartilage level. Then it travels intermedially away from the brachial plexus, an additional 3 mm separation for every centimeter separation more distal in the neck. This can be demonstrated clearly by ultrasound tracing, where you can see the phrenic nerve near the C5 root is moving away from the brachial plexus as it descends into the root of the neck. The phrenic nerve is not always visible in every patient, but in this skinny patient, you can see the phrenic nerve superficial to the anterior scalene muscle. In this video, you can see the phrenic nerve here is moving medially as the probe is scanned in caudate direction. And there are several ways to assess the severity of the phrenic nerve palsy, including pulse oximetry and pulmonary function testing using spirometry and diaphragmatic ultrasound. And among these methods, the diaphragmatic ultrasound is reported to show 93% sensitivity and 100% specificity in diagnosing phrenic nerve dysfunction. On patient's right side, the curved transducer is used to visualize diaphragm in the mid-clavicular and right subcostal margin using the liver as the acoustic window. And on the left side, the linear array transducer is used in the left mid-axillary line at the level of ribs 8 and 9. Once a hyperechoic diaphragmatic line here is obtained, M-mode sonography is used to quantify the extent of diaphragmatic excursion. Here you can see the movement of the diaphragm during the sniff test, where the patient is asked to inspire rapidly and through the nose, but after the interscalene block, the diaphragmatic movement is absent during the sniff test, indicating complete hemidiaphragmatic paresis. In this video, you can see the movement of the diaphragm during the inspiration and expiration. You can see this is a diaphragm, and you can see it moves as the patient inspires and expires. This is M mode of diaphragmatic movement. You can clearly see the normal movement of diaphragm in the pre-block assessment, but at 30 minutes after interscalene block, there is no movement, suggesting for the complete phrenic nerve palsy and associated hemidiaphragmatic paresis. In some patients, partial hemidiaphragmatic paresis can occur, and diaphragm excursions are measured before and after the interscalene block, and the percent decrease in diaphragmatic excursion is calculated. In this patient, there is 42.5% reduction at 30 minutes after the block, suggesting for the partial block. In general, complete hemidiaphragmatic paresis usually defined as 75 to 100% decrease or the occurrence of the paradoxical movement. And partial paresis is defined as 25 to 75% decrease in diaphragmatic excursion compared with the pre-block assessment. Then what are the strategies for reducing phrenic nerve palsy? Several modifications to the interscaling block as well as alternative techniques have been tried and tested. These strategies include decreasing local anesthetic dose and volume, and performing the block at the location away from the phrenic nerve, such as superior trunk block, and selectively blocking suprascapular and axillary nerves. First, let's take a look at decreasing local anesthetic volume. The direct visualization of local anesthetic deposition by ultrasound has enabled regional anesthesiologists to decrease the local anesthetic volume while ensuring the block success rate. In this study, the incidence of diaphragmatic paresis was 45% after injection of 5 milliliter of 0.5% ropivacaine versus 100% with 20 milliliters of local anesthetic injection. And notably, there were similar pain scores, sleep quality, and total morphine consumption up to 24 hours after surgery between the two groups. However, in clinical practice, such low volume may not consistently produce sufficient analgesia where regional blocks are often performed by residents and trainees. Next method is to perform a block away from the phrenic nerve, such as superior trunk block. Superior trunk block is an example of refinement of existing block and is intended as an alternative to conventional interscaling block. And superior trunk block was introduced by Dr. Chin and colleagues as in this case report. The C5 and C6 roots unite to form superior trunk, and all the terminal branches supplying the shoulder rise distal to the origin of the superior trunk, and hence analgesic efficacy is not compromised. The probe image is where conventional block is performed, and dotted rectangles indicate the location of the superior trunk block. Also, the phrenic nerve, as indicated by the black arrows, is descending in a medial direction over the anterior scalene muscle away from the brachial plexus. And at superior trunk level, the phrenic nerve has diverged a considerable distance away from the brachial plexus. These figures show sequential series of images of the brachial plexus. Figure A shows C5 and C6, and figure B, the phrenic nerve is visible, pointed by white arrow on top of anterior scalene muscle. And in figure C, C7 is visible, and figure D, C5 and C6 roots have coalesced into superior trunk. In this figure, superior trunk lies just under the deep cervical fascia, marked by a dotted line, and suprascapular nerve is visible as it is about to separate from the superior trunk. You can also see the middle and inferior trunks deep to the superior trunk. Here you can see the suprascapular nerve branching out and continuing to move laterally as the plexus is scanned more distally. Therefore, it is very important to perform the block before suprascapular nerve branches out in order to achieve complete block of the shoulder. Now, let's take a look at the efficacy and safety of the superior trunk block. In 2019, 2 manuscripts on the superior trunk block were published in Anesthesiology. First, Dr. Kim and colleagues assessed whether superior trunk block would provide non-inferior postoperative analgesia compared with the interscaling block and reduce hemidiaphragmatic paresis in patients undergoing arthroscopic shoulder surgery. And they showed that when interscaling block was compared with the superior trunk block, less frequent hemidiaphragmatic paresis was seen in the superior trunk block group, and further, it was not non-inferior to interscalene block in terms of worst pain scores in the recovery room. The figure A shows superior trunk, middle trunk, and inferior trunks in the blue circles, and figure B and C show that the suprascapular nerve in yellow circle is branching off the superior trunk. The figure D shows that block needle is placed posteriorly to the superior trunk as local anesthetic is spread as seen in yellow highlight. And figure E shows that the block needed is repositioned anteriorly and laterally to the superior trunk, and the local anesthetic is injected at this point. And they showed that the superior trunk group had a significantly lower incidence of hemidiaphragmatic paralysis compared with the interscalene group, with the incidence of 4.8% versus 71.4% respectively. And the worst pain scores were similar between the two groups. And they concluded that compared with the interscalene block, the superior trunk block provides non-inferior surgical anesthesia while preserving diaphragmatic function. And thus, superior trunk block may therefore be considered as an alternative to a traditional interscalene block for shoulder surgery. This study was performed in our institution, and I would like to introduce Dr. Kang and Dr. Chung, the member of our regional anesthesia team. And in this study, we assessed whether the superior trunk block would provide non-inferior postoperative analgesia compared with the interscalene block and reduce hemidiaphragmatic paralysis. In this figure, the needle is advanced in plane in the lateral to medial direction until the needle tip is positioned adjacent to the lateral border of the superior trunk. And the injection of local anesthetic at this point hydrodissect the tissue plane around the superior trunk, and 20 milliliters of local anesthetic is spread around the superior trunk with minimal need for needle repositioning. And you can see the spread of local anesthetics around the superior trunk. And in this study, we showed that the pain scores at 24 hours postoperatively was similar between the two groups, and the analgesic requirements and all other pain measurements were similar between the two groups. And importantly, hemidiaphragmatic paralysis was observed in 97.5% of the interscalene block group versus 76.3% in the superior trunk block group. However, more importantly, the paralysis was complete in 72.5% in the interscalene block group versus only 5.3% in the superior trunk block group. And this has a significant clinical implication because diaphragmatic function will still be preserved in some degrees after superior trunk block anesthesia. And next, the risk of phrenic nerve palsy might be eliminated by selectively blocking suprascapular and axillary nerves. The suprascapular nerve provides sensory fibers to approximately 70% of the shoulder joint capsule, and it can either be blocked in the suprascapular fossa or in the root of the neck distal to where it arises from the superior trunk and brachial plexus. And next, the axillary nerve is terminal branch of the posterior cord of the brachial plexus, and it can be blocked in the anterior chest or, as seen in this figure, posterior to the humerus as it emerges from the quadrangular space. In arthroscopic shoulder surgery, suprascapular and axillary nerve block is less effective as shown by higher immediate postoperative pain scores compared with interscalene block. Nevertheless, this technique has not been associated with any reported episodes of phrenic nerve palsy and probably best reserved for patients with pre-existing respiratory dysfunction. And lastly, the hemidiaphragmatic paralysis is also common after supraclavicular brachial plexus block. And this study, performed in our institution, we compared the incidence of hemidiaphragmatic paralysis in patients who had local anesthetic injection, primarily in the corner pocket, defined as the intersection of the first rib and the subclavian artery, with that of patients who underwent injection primarily inside the neural cluster. In corner pocket group, 20 milliliters of local anesthetic was injected in the corner pocket, and then 5 milliliter of local anesthetic was injected inside the neural cluster. And in the neural cluster group, local anesthetic was deposited primarily inside the neural cluster and secondarily in the corner pocket. And in this study, we showed that the incidence of hemidiaphragmatic paralysis was significantly lower in the corner pocket group versus neural cluster group, with the incidences of 27.8% versus 66.7%. And thus, we concluded that the incidence of hemidiaphragmatic paralysis was effectively reduced when local anesthetic was injected primarily in the corner pocket during right-sided supraclavicular brachial plexus block. And in summary, the incidence of phrenic nerve palsy is very high after conventional interscaling brachial plexus block, and it can lead to significant complication in high-risk patients. And then how can we decrease the incidence of phrenic nerve palsy? Those strategies include decreasing local anesthetic dose and volume, and performing the block at the location away from the phrenic nerve, such as superior trunk block, and selectively blocking suprascapular and axillary nerves, or using corner pocket injection technique for supraclavicular block. And thank you for your attention. And I would like to take this opportunity to promote AACA 2022 in conjunction with Korea Anesthesia 2022, which will be held between November 10 and 13 at COEX, Seoul, Korea.